Thank you, Athena. So yes, I am talking about binge eating disorder and diabetes, which seems like a very specific topic to be discussing at this conference. And a lot of you might think that it's rare and might not warrant an entire conversation, but as you will learn sort of throughout my talk, that the prevalence is probably a lot higher than we might think. I'm curious to know if anybody in this room has ever diagnosed somebody as having binge eating disorder. If you feel comfortable, would you raise your hand? Ken Fujioka is here, he definitely has. Anybody else? Nobody else, really? Lori definitely has, come on. Anybody else? Okay, so my goal is to make it so that next year, when I ask the same question of the audience, everybody puts their hand up unless you are not in clinical practice, okay? So here are my disclosures. Our goals today are to talk about the diagnostic criteria for binge eating disorder, to talk about the tools we have to manage it, and then to talk about weight loss strategies in patients who suffer from binge eating disorder. So we're going to go through a case. This is Jennifer. She's a 26-year-old woman who's frustrated with her inability to lose weight. She's been overweight from a young age. She's gone to diet clinics. She remembers being brought by her mom at age 11 to Weight Watchers. She's tried multiple plans. And despite losing as much as 30 pounds with lifestyle interventions, she always ends up falling off the wagon and regains the weight rapidly, usually above where she ended up starting from. She was recently told that she actually has prediabetes. She is trying to lose weight by counting calories. She's using an app on her phone, about 1,400 calories per day, and doing intermittent fasting 16 and 8, so 16-hour fasting window and 8-hour eating window. Other history, her BMI is 33, so she is in the obesity range. Past medical history, PCOS, this new prediabetes, and a history of depression. By the way, I should comment too. I don't know if you guys have noticed, but I'm using images depicting somebody who is struggling with their weight in a positive way. And a lot of times this is not done. Pictures of people in the media or in articles who are struggling with weight are often depicted as being lazy. And I've shown other slides in other conferences of people, unable to fit in their clothes. So the Obesity Action Coalition is an advocacy organization trying to promote better understanding of obesity as a disease, difficulty, and really empowering patients and seeing them as people who are trying hard, are not lazy, or not unmotivated. So they have a free deck of stock photos that you can use if you ever give a presentation and want to use these types of images. Her current medications, metformin and sertraline. Other pertinent history, she's married, she's a paralegal, her menses are irregular, she's considering going on birth control pills, does not plan to have kids anytime soon, and is using condoms as contraception. Her typical daily diet, so she skips breakfast in the morning, she might have coffee with creamer. Lunch is light, so salad, an apple, string cheese, and then dinner is her largest meal, usually protein and vegetables. After dinner, she might have a snack like some popcorn or a piece of chocolate. She walks her dog, she does yoga sometimes. So why isn't she losing weight? Is it possible that her medications are affecting her weight? Does she have another condition that we haven't screened for that might be affecting her weight, such as sleep apnea? Is she eating too many calories? Is 1,400 too many for her? Are 1,400 calories too low for her, or the starvation mode that a lot of people talk about, which is highly debated? Is she not active enough? What are we missing? So upon further questioning, she will tell you that she is on for a few days in a row, sticking to her calorie goal, and then suddenly will feel these intense urges to overeat and will completely fall off the wagon. She's either completely on plan, on track, or she is completely off track and gaining weight. This happens about 3 to 4 times per week, usually in the evenings after dinner. So when you ask her, tell me about the most recent time this happened, tell me about the episode, this is what she says. On Wednesday, I had a stressful day at work. I was tired. I felt like I was starting to get PMS symptoms. A few hours after lunch, I couldn't stop thinking about a burrito from my favorite fast food restaurant. I knew my husband was going to make grilled chicken, but I literally felt like I had to have this burrito. I was anxious thinking about it. I had this sense of urgency, almost like a panic. I can't really explain it. After work, I went to the fast food place. I got nachos, a quesadilla, a burrito. I sat in the parking lot in my car. I ate most of it. I inhaled it. I couldn't even finish the burrito. I felt so sick after eating so much. I threw away the wrappers and the leftover burrito outside the restaurant so my husband wouldn't know I'd eaten. I got home, told my husband I wasn't very hungry because I had a late lunch. A few hours later, though, I felt snacky again. I had a bag of chocolate-covered pretzels while watching TV. That was around midnight. My husband was asleep. I waited until he went to bed because I know he'd be mad that I hardly ate a healthy dinner and then ate crap. He knows I really want to lose weight. I'm so mad at myself. I had been really on plan for the week and was reaching all my goals. I keep messing up. I don't know what's wrong with me. I want to lose weight, but then I lose motivation and mess up. It's embarrassing. Does Jennifer have binge eating disorder? Okay, yes, we know the topic that I'm talking about. Spoiler alert, you guys knew that already, but what is binge eating disorder, right? How did she meet the criteria? What about her story is important to know? And it's kind of going to be, throughout the talk, sort of how this relates to the scenario that I've presented. So binge eating disorder, simply put, is defined as consuming a larger than normal amount of food while feeling a lack of control with respect to the ability to stop eating. And it doesn't have to be a giant sheet cake. There's no amount of calories that have to occur in an episode. It just has to be, more than normal in the sense of lack of control. So let's go through the DSM-5 criteria. Has to have 2 criteria to start. Recurrent episodes of binge eating characterized by eating, usually in a short period of time, so within 1 to 2 hours, an amount of food that is definitely larger than most people would eat in a similar period under similar circumstances, and a sense of lack of control. What else? You need to have at least 3 of the 5 following criteria: eating more rapidly than normal, eating until uncomfortably full, eating large amounts with non-physically hungry, eating alone because you're embarrassed, and then afterwards feeling disgusted, depressed, or guilty. These episodes have to be distressing. This is not a gentleman who goes to a football Sunday party and has 30 chicken wings and a beer, and yes, he's eaten 3,000 calories, but he doesn't feel bad about it. He's not distressed over the episode. That is not what binge eating is. The episodes have to occur at least once per week for 3 months continuously, and this has changed over the years. It used to be required to be more frequent in order to be diagnosed as binge eating disorder. And then no compensatory mechanisms, for example, not purging, because that would be considered bulimia and not binge eating disorder. And then the severity of binge eating disorder is by the episodes per week, and you can see on the left-hand side what the classifications are. So why wasn't it clear that she had binge eating disorder? It's probably hugely underdiagnosed. We aren't asking enough, and patients aren't telling us enough. So when I asked everybody here, has anyone here diagnosed somebody with binge eating disorder? Not that many people raised their hand. Part of the problem might be that we simply are not asking the right questions to elicit those type of responses from patients. But also, patients don't tell us. Providers and patients think that it's some type of character flaw, like there's a willpower or a motivation issue that's causing it, and it's embarrassing to admit to something like that. There's so much shame and embarrassment that comes along with it that patients might not bring it up. And it's estimated that less than 20% of patients with binge eating disorder are actually seeking professional help, and with an annotation that they're not usually seeking help for binge eating disorder. They are coming to see people because they want to lose weight, and it just so happens that they have binge eating disorder. So what is the prevalence? Definitely more common than we think. Somewhere between 2 and 3.5% of the population, although some studies suggest it might be as high as 20% in patients with type 2 diabetes. So next year, if you guys are working with patients with diabetes, when I ask, I hope at least you found one person with binge eating disorder, because if 20% of patients with type 2 diabetes are suffering from this disease, and we are interacting with patients with diabetes all the time, almost every day we are coming in contact with somebody who has binge eating disorder. Women seem to be affected more than men, 3.5 versus 2% lifetime prevalence. People seeking weight loss programs is probably somewhere around 30% of those people might have binge eating disorder. And in people who are pursuing bariatric surgery, it can be as high as 50%, so really important to screen. The median age of onset is around 23 years of age, and it lasts a long time, more than bulimia, more than anorexia. It's 14-year average duration. The other two are 6-year duration. The presentation can vary, so some people just don't feel satiety. Others feel a drive to overeat with a sense of reward, and there's a lot of areas in the brain involved in eating behaviors, and it can be very complex, and a lot of these things can go wrong, resulting in binge eating disorder. So what about a correlation with mental health? There is a high likelihood, a much increased likelihood of other psychopathology and personality disorders in people who suffer from binge eating disorder. Really important to recognize and treat concurrent psychopathology. One study showed of about 400 patients with binge eating disorder at the time of diagnosis, over 40% had another psychiatric disorder, and the odds of a lifetime psychiatric disorder was almost 74%. So what types of disorders? Primarily mood, such as depression, anxiety, substance use, personality disorders, other type of obsessive compulsive disorders or addictions are very common because it's affecting the similar parts of the brain that are affected in binge eating disorder. What about metabolic disease, right? That's what we're here to talk about. We're talking about diabetes. Binge eating disorder is highly associated with obesity, metabolic disease, and type 2 diabetes. Those with binge eating disorder are more likely to have metabolic disease when you match them with peers who are the same body profile and weight but don't have binge eating disorder. So even at the same weight, they're more likely to have metabolic disease. People with binge eating disorder, compared to those without it, are at a 13-fold increased risk of developing type 2 diabetes, and it appears that binge eating alone can increase this risk for metabolic disease and worse glycemic control in patients who already have diabetes. So why is there a link between metabolic disease and binge eating? It's not completely known, but there are a lot of theories and a lot of studies have shown some abnormal findings. So perhaps this really high fat, high calorie load leads to an acute insulin resistant state, high levels of insulin, which promote weight gain and metabolic disease, high cortisol levels from the stress of the whole event, leading to insulin resistance and gluconeogenesis or production of glucose. Other inflammatory and hormonal derangements have been found as well. So binge eating disorder is associated with higher ESR levels, CRP, white blood cells, showing there's a higher risk for other inflammatory states. And then the effect of insulin in people who are taking it exogenously can lead to weight gain, as we know, but there's also, a lot of undiagnosed hypoglycemia, which can lead to defensive eating and compensatory hunger, where people's appetites, if you've ever had a low blood sugar, the urge to eat can be so intense. Of course, it's hard for people to limit how much they treat their hypos with, right? Because the urge is so intense, and this can result in binge eating behavior as well. So why is it important to diagnose and treat? It's associated with metabolic disease, it's associated with inflammation, poor mental health, but also it's exquisitely painful for people who are suffering from binge eating disorder. They feel a constant preoccupation with food, eating, their weight, trying to lose weight, and they're ashamed, they feel guilty and embarrassed. It's just a very distressing, uncomfortable thing to live with. So you really have the ability to make a huge impact in people's lives when you treat underlying binge eating disorder. So here are my recommendations for screening tools. Keep it simple. Find a one-liner. Do you ever eat large amounts of food and feel out of control? Or do you ever feel like you're overeating, can't stop yourself even if you wanted to? Follow it up if they say yes. After these episodes, do you feel bad? Do you feel physically sick, emotionally upset? Are you ashamed? Do you beat yourself up? And as you get through it, you can kind of run through the DSM-5 criteria. My goal from today, like I said, is to make sure everyone starts screening almost essentially every patient that you are coming across. Pick any screening tool or screening question that you'd like and use it 100% of the time. The BED7, a binge eating disorder screener 7, is an easy handout that you can get online, so I included it so that you can look through it with some screening questions and then going into more detail if patients answer yes. So what are some of the causes of binge eating disorder? So there are genetic causes, various receptor mutations, particularly the MC4R receptor. There's strong correlation in twin and family studies, not just for binge eating disorder, but other addictive or obsessive compulsive disorders. Different family members might have different diseases, but they seem to be more likely in certain genetic families. A history of impulsive compulsive behavior or another addiction history seems to correlate with greater likelihood of binge eating disorder. And then perhaps there's some type of interaction with gut flora, which might be genetic or might not. Medications, so antipsychotics in particular, can precipitate it. It's very important to get a good medication history. Dopaminergic medications, diabetes medications, as we talked about, in particular those that might cause hypoglycemia and potentially steroids. So in terms of medications, those that especially are affecting the dopamine pathways and the 5-HT2C pathways seem to result in more binge eating behavior. Also, this history of restriction, I have particular interest in this. But there's this restraint theory in set point where your body, your brain wants to be at a certain weight and it fights really hard to maintain that weight, okay? So if you have any type of deprivation or caloric restriction, fasting, even low carb, a perceived type of famine, the body might fight really hard to counteract that by increasing appetite. And we'll go through a little bit about why this might happen. And perhaps people who are at a genetic predisposition, once they do some type of restrictive eating plan or some type of restriction, they then are triggered to have binge eating disorder because of some underlying genetic predisposition. So is binge eating somehow adaptive? On the left here is a picture of the Donner family. So if those of you who are familiar with this family, this was in the 1800s. This was a large group of settlers that were moving out west. And they got stuck. They got stuck in the snow. And I think everybody knows them. They're sort of famous for cannibalism, right? So they were starving to death, and it turns out some of them ate each other in order to survive. That is not why I'm telling this story. Okay? I mean, yes, people will go to extreme measures to survive, right? And we can't really judge anybody in that state unless we were in that state. But what always interested me, I used to be very interested in this story, is not just what they did to survive, but what happened after they were rescued. So after they were rescued, they were aware of refeeding syndrome. They knew that if you overate after a period of starvation, you could die. So they very gradually had the people that they saved increase their food intake. But the drive for them to eat was so intense that some of them could not control themselves. And there was at least one person who, after rescue, died from overfeeding. They were found, the story goes like in the middle of the night, he left and went to where the food storage was and basically ate himself to death and was like found with food in his pockets outside. Basically, the drive was so intense that they couldn't hold themselves back. Similarly, I don't know if you guys are familiar with the Minnesota starvation studies. This was done in the 1940s during World War II to understand the effects of starvation on the body. So these young, healthy men, instead of going to war, they were in like an inpatient type of unit where they were forced to lose weight on a low-calorie diet. And these men became obsessed with food. It's all they talked about. They read recipes to each other. They watched cooking shows on TV. They were so obsessed, they started to develop disordered eating. And when they did have access to food, they couldn't control themselves. They were hoarding food. They got angry if another subject threw away food. They went on to have careers. Some of them went into culinary fields. They were literally obsessed with food and developed binge eating. Some people even would end up purging because they would overeat and feel so sick. So the theory is, after some period of true or perceived famine, perhaps those who overeat when they have access to food are going to be better able to survive for future periods of famine. And they're trying to get back to their brain set point even higher, if possible, to protect themselves, okay? Studies have shown that being overweight often occurs before development of binge eating disorder, with dieting and binge eating occurring later. People are not becoming overweight just because they're binge eating. They're overweight, they diet, they develop binge eating. Not in everybody, but in a lot of scenarios. The neurobiology is complicated, and I won't get too in detail, but I will highlight a few of the problems that are misfiring. So the reward system doesn't subside. People are not getting that feel-good sensation that they should be getting from food, and they need more to try to feel any type of reward. Their impulse control is underactive. They are not able to control their impulses, hence the relationship with other addictive types of behaviors. The emotions, so a lot of times people do emotional eating, right? They feel poorly. But the truth is, after they eat because they think they're going to feel better, but after a binge eating episode, they actually feel worse because now they're also beating themselves up about this episode. Ghrelin, we know that after any type of weight loss, ghrelin, which is a very potent, important hormone released from the gut, from the stomach, after a weight loss attempt, ghrelin levels increase. So at some points, your ghrelin levels, which stimulates appetite, might be as high after a meal as it used to be before a meal, meaning people are going to be hungrier. It takes more for them to feel good. So all of this leads to this non-hunger eating, or this impulsive compulsive disorder with alterations in reward and food-related attentional biases. Why am I telling you guys all this? Offer sympathy to patients. Remind them they are not abnormal, right? You can tell them there is not a lack of willpower or laziness causing this. It's not your fault. There is a neurobiological basis. There's an evolutionary mechanism, which is probably a good thing and would have kept you alive, 2,000 years ago. And there are evidence-based strategies to help move towards recovery. So let's talk a little bit about dietary strategies. Because of this yo-yo effect that I've mentioned, where when you restrict, you become hungrier, a lot of times it's recommended to avoid dieting in people who have binge eating disorder. Eat regularly, don't skip meals. Listen to your body, intuitive eating, listen to your hunger, satiety cues. The problem is people with binge eating disorder are often coming because they want to lose weight, not because they want treatment for their binge eating disorder, although they want that too. They want both, right? Improvement in binge eating disorder and weight loss. So does intuitive eating, does listening to your body, is that enough to also help them lose weight? And honestly, there's debate over this, and we'll talk a little bit more about what studies have shown. So there are some dietary interventions done in people with binge eating disorder that have shown you can do a very low-calorie diet resulting in weight loss, and it might not actually worsen binge eating behavior. There's even a study on low-calorie ketogenic diets, and people found that the addictive element of food seemed to disappear. I know we heard about ketones this morning and some of the benefits, but some people do find that low-carb diets kind of cure them of food addiction and cravings. But really, you need to individualize the approach. So there is never a one-size-fits-all approach in any aspect of weight loss. You need to listen to patient preferences, their cost concerns, lifestyle. If you know they don't do well with excessive restriction, try to avoid it. You don't want to eliminate an entire food or an entire food group in somebody who gets triggered and then will overeat or binge on this food group. And don't be afraid to try an eating plan, especially if you couple it with medication and therapy. Definitely refer to a dietitian who has experience in binge eating disorder. If you are not a dietitian who has experience in binge eating disorder, I'm sure there are some here. And then what about therapy? So CBT, or cognitive behavioral therapy, seems to have the best data on decreasing binge frequency. It really helps people develop awareness of their eating behaviors. They monitor themselves, recording things, their mood, their thoughts, their behaviors, trying to change that, learning to problem solve, and also establish a healthier relationship with food and healthy eating patterns. Psychotherapy has been associated with about a 50% binge eating abstinence rate at 12 months, but that can wane. So you really need to continue long-term sort of intensive therapy in order to maintain some of the benefit when it comes to binge eating disorder. Has not really been shown to result in weight loss, although if somebody achieves binge abstinence or is no longer binge eating, there is a potential for some weight loss. Overall studies are limited, and there are some other forms of therapy that do have some data as well on improvement. One of my clinical pearls would be to keep a list of people local to you who specialize in eating disorders, like a psychologist or a therapist, just to have on hand as a resource to give to patients if you do identify that somebody is suffering from this disease. So let's talk about medications. Because binge eating disorder is a complex condition with multiple pathways, a variety of treatment targets may be effective, and over 20 medications have been studied in regards to treating binge eating disorder. And this is a table that came from an article I published with Ken Fujioka, who's sitting over there, basically showing some of the top medications that have been studied. You will notice that only one of these medications is actually FDA approved for binge eating disorder, and that's lisdexamfetamine. That doesn't mean it's the only medication used. There is a lot of off-label use for the treatment of binge eating disorder that is supported by data. So for example, topiramate, or an anti-epileptic medication, has been shown to have pretty profound benefit in binge eating disorder. And then a lot of the traditional diabetes or weight loss medications like liraglutide, which is a diabetes and a weight loss medication, naltrexone bupropion, a weight loss medication, phentermine topiramate, also a weight loss medication, and then fluoxetine, which is actually an SSRI. All of these have data and improvement on binge eating disorder. So in some ways, you can also treat it just like you would treat somebody else suffering from obesity in terms of various types of medications you can use. What about bariatric surgery? So we have Ken Fujioka is going to talk next, and then we have Mark Takata, a surgeon at Scripps, who's going to be talking about bariatric surgery. So I thought it was important to highlight on this too. So binge eating disorder is very commonly seen in patients, especially those with a BMI above 40, although it's also common in people with a lower BMI who might qualify for bariatric surgery. So to qualify for bariatric surgery right now under insurance, you need a BMI of 35 or above with a comorbid condition related to obesity requiring treatment, or a BMI above 40 or equal to 40, regardless of any other metabolic complications. Binge eating disorder is the second most common psychiatric disorder seen in those pursuing bariatric surgery, the number one being depression, major depressive disorder. And there's a wide variety of data results out there in terms of the prevalence of binge eating in patients pursuing bariatric surgery, but it's somewhere between 4 and 50%, probably 20 to 30% would be the most accurate, which is a lot, right? That's a lot of patients. Binge eating disorder is associated with worsened outcomes after bariatric surgery. There's post-op complications, less weight loss, stretching of the surgical pouch, more need for a surgical revision, but also sometimes people trade one addiction for another. So if before surgery, food is where they turn to for comfort, after surgery, they might turn towards something else, more likely to develop other types of addictive behaviors, gambling, drug addiction, tobacco use. So can people with binge eating disorder have bariatric surgery? I mean, if somebody is actively binge eating, It's absolutely contraindicated. But these are patients that we just said at the same weight as a counterpart who does not have binge eating disorder. They are at much higher risk for developing metabolic disease, right? And the more we know about bariatric surgery, the more we know that it is a really powerful tool for metabolic disease, right? It's no longer just bariatric surgery, it's surgery for metabolic disease. So to rule that out completely in this population might not be doing them a huge amount of service, but I think you can still consider it as an option. They always need to undergo a pre-surgery psychological evaluation, and that is a requirement by insurance in order to cover the surgery. So they will look about eating habits and other types of addictive behaviors and binge eating to make sure they're not actively binge eating. And you really need to treat it aggressively before surgery with therapy and medication and have it improved, not actively a condition, but ideally achieving binge abstinence prior to undergoing any type of surgery, and then always continue to address it in the peri and post-op setting with very close monitoring. Binge eating disorder requires a lot of providers coming together in order to treat it. It's rare that one provider is able to address all of these different elements that I've talked about. So who is involved in this type of care? A physician or a provider, such as an obesity medicine specialist, an endocrinologist, a primary care provider, a psychiatrist, someone who has expertise in the mental health surrounding this, so a therapist or psychologist, a dietitian who has experience in treating eating disorders, a diabetes educator if these patients have type 1 or type 2 diabetes, especially if they're on insulin or sulfonylureas or something that might cause hypoglycemia. And then various forms of group support, so OA, Overeaters Anonymous potentially, or other group therapy sessions. There are some local psychologists who also have these cohorts of groups of people suffering from binge eating where they can kind of talk to other people who are suffering from the same condition and not feel so alone in the disease. How do we monitor for improvement? Have patients measure the number of episodes per week or per month, and you can also have them write the severity, okay? Remind them that the goal is not to have 0 episodes and complete resolution. The goals are a reduction in the frequency and severity of binge eating. It's not always going to be, a constant improvement in disease. It might be stepwise, and sometimes people might get a little bit worse before they get better, and that's why tracking can be helpful so that they can see big picture if they're improving or not. The goals are also for weight loss if patient is desiring it, or prevention of weight gain, especially now that we know that they're at such a high risk for metabolic disease. We want to manage their comorbid conditions and improve glycemic control. We want to improve the mental and emotional burden that comes with binge eating disorder. These patients are really suffering, exquisitely suffering, and improving that psychological aspect will be very beneficial for them. Here is a table sort of recapping what I had mentioned, and these are treatment options to consider for patients with binge eating disorder and type 2 diabetes. So the dietary modifications, behavioral interventions, pharmacotherapy, and then potential surgery. And then just like the ADA algorithm, always assessing for response to any intervention by evaluating for improvement, such as amount of episodes per week. Here are some resources. There is no shortage of resources. Lots of books. So here are some of the more popular ones: Brain Over Binge, Intuitive Eating, which I had mentioned, the Binge Code. I read reviews for this. I didn't read the book, and a lot of people complained that there was a donut picture on the cover. They felt that that might be triggering for people who have binge eating disorder. So yes. There are websites, so the eating disorder websites, bingeeatingdisorder.com is a great resource. Group support, like I mentioned, Overeaters Anonymous. I just typed into Facebook binge eating and I found groups. This one has 11,000 members for binge eating, food addiction, emotional eating support. So there's no shortage of groups and resources out there to help people feel less alone, because people often feel like what they're suffering from is really rare and nobody understands what they're going through. So let's go back through the case. This is Jennifer. I tried to incorporate things. So for example, she said she had PMS, and as it turns out, there's some hormonal influences during this luteal phase of the menstrual cycle that might also promote binge eating. So there is also potential time of month relationship. So what's our plan with her? We are going to reassure. We're going to express sympathy or empathy, telling her that there is a neurobiological basis for what she's suffering from, or you can use a different word than neurobiological if it's a patient. Biological. Prescribe medication if you have the capacity to be a prescriber. I think that is one of the strongest tools that we have out there to really help with this disease. Refer to an experienced dietitian. She is somebody who might not do well skipping breakfast. Intermittent fasting has gotten really popular. People are really light in the morning and heavy in the evenings, and that might actually set them up for worse in binge eating. So this would be someone I might say don't skip meals or front load if you are going to do time-restricted eating. Consider avoiding excessive restriction, add in exercise, consider a sleep study, mental health provider, and then educate on how to monitor for improvement. In conclusion, binge eating disorder is a common, underdiagnosed, distressing disease associated with metabolic disease, inflammation, and psychiatric disorders. So screen for it, get a thorough history, treat with multiple tools available to you, and make sure to refer out when needed. And like I said, it's probably needed unless you happen to be an expert in binge eating disorder, because there are so many disciplines that really require targeting to treat this fully. Thank you. Thank you. So while I'm up here, I'm going to introduce the next speaker. So Dr. Ken Fujioka is here speaking. He is the director of the Nutrition and Metabolic Research Center and Scripps Clinic. He frequently lectures at national conferences, speaking on the role of weight control and diabetes, and has published numerous research papers, lots of clinical trials in the field of obesity and related diseases. He's really an expert, a father or grandfather in the field. I'm not sure which one to use, but one of those. So we're really fortunate to have him here today.